Good afternoon, colleagues. It's a pleasure having you, ladies and gentlemen, to today's eco session. Thank you all for logging in from wherever you are. Our topic for today is approach to a crying and irritable child. And children are unique. The way we manage adults is not the same way. Today we bring you expert pediatrician to discuss the topic on how to adequately manage such children. We also bring you pre-hospital care provider. As we all know, emergencies happen everywhere, not only at emergency department. It's very vital to resuscitate, stabilize, provide ongoing care during transit until the receiving facility. At this moment, we shall have introductions of the experts. Experts, you're most welcome to today's eco session. We shall have introductions. I'll start from my right, then left. Dr. David, you're welcome.
Good afternoon, everyone. I'm called Dr. David Amwilumuri. I'm an emergency medicine resident from Makerere University. I'm privileged to have an opportunity this afternoon to be your case presenter. Thank you.
Thank you, Dr. David. We are glad to have you as one of our experts, case presenter. You're welcome.
Thank you very much, moderator. Ntambi Umar are my names. Once again, I want to say thank you to Sing Global, with support from Ministry of Health, for giving us the opportunity to come and try to share here and there. And we look forward to learning from the audience, but also trying to present the experience that have been picked.
Thank you so much. We have our pediatrician who will be having their discussion or presentation online. At this moment, I welcome Dr. Sabrina to kindly unmute herself and introduce herself to the audience.
Good afternoon, everyone. Thank you very much, the moderator. My name is Sabrina Chitaka. I am a pediatrician. I also teach here at Makerere University. I teach pediatrics and adolescent medicine. Thank you very much to the EMS SEED project, and I'm looking forward to having a great discussion. Thank you.
Thank you, Dr. Sabrina. We are privileged to have you for this session today. At this moment, I welcome Dr. Ojambo. Dr. Ojambo, who is going to be our chat expert, to kindly unmute himself and introduce himself to the audience. Dr. Ojambo. So Dr. Ojambo will be joining us shortly. At this moment, we shall have session expectations. I know as all of us were logging in for this session, we had expectations. Kindly type your expectation through our chat. I'll give opportunity to 2 people to raise up their hands and tell us what the expectations are for the session. Thank you. Kindly keep on typing your expectation through our chats. 2 people who can tell us what the expectations are. your expectation through our chats. And 2 people, kindly tell us your expectations as we proceed to our next agenda of the session. Those are the messages, that's what I wanted. Maybe you come and guide me. If I can read through some of the expectations. Kalisa Ruth wants to know crying irritation due to colic, neonates. Then Okot Janan wants to understand the causes of irritability versus crying. Let me read the last expectation in the chat. Maximum Mwima wants to know the probable causes of irritability in children of varying age groups. Thank you all. Your expectations will be met by the end of the session by our experts. At this moment, we are going to have our case presentation. We have Dr. David Mwirumbi, who is going to take us through the case presentation. And as he presents the case, we shall be sharing a poll for discussion within the case presentation. Feel free to type your responses through our chats. Dr. David, you're welcome. Kindly take us through your case presentation.
Thank you, our dear moderator. This afternoon, we are going to discuss a case of a 3-year-old female who was brought to the pediatric acute care unit at Mulago by the mother and the auntie. The chief complaint was inconsolable crying, irritability, and refusal to bear weight for 2 days. However, the history revealed a chronic pattern, and the mother reported that the child is generally clumsy and falls frequently, which leads to multiple bruises and injuries over the past 1 week. Also, the patient had progressive pallor and decreased appetite for 1 month. However, the history was a little bit vague and could not account for the pattern of injuries this child was presenting with. So from this history, we went ahead to do a primary survey. The primary survey on the airway was parted because the child was crying and was able to talk. The child had no stridor. The breathing was non-labored, was symmetrical. Breast sounds were clear, no auscultation. She had no grunting, no flaring, and respiratory rate at this point was 38 beats per minute, and air entry was equal, no wheezing, and no crackles. The SpO2 was 92 on room air. The circulation, the heart rate was 148 beats per minute. The BP was 92 out of 50. The capillary refill was 4 seconds. The peripheries were warm, and she had no active external bleeding. Disability, using the AVPU, she responded to voices. She was slightly irritable. The pupils were equal and active. At this point, we also did an RBS, which was 5.2 millimoles, which we found to be normal. When we exposed her, the temperature was 37.5. She had multiple bruises over the back. She had a yellow brownish pigmentation on the arms and legs. And then she had echinosis. And then she had also echinosis over the right arms, and also there were some bruises and deformity in the right thigh, which we could visibly notice. So from our primary survey and history, I think our dear moderator can take us through this discussion for sure.
Thank you, Dr. David. As earlier said, we shall have these discussions in between the presentation. At this moment, what are the emergent conditions to consider? Kindly feel free, type your responses into our chats, all will be responded to. This will take 1 minute, and so far we have 150 people on the call. Thank you all. Yes, doctor, you can continue.
Yes, some of the, based on the history and the primary survey we have, some of our emergency conditions that we would come up with, and I hope they also align with what you're thinking. We thought about occult head injury, we thought about internal abdominal injury, toxic injections, sepsis, non-accidental trauma, pain, crisis, musculoskeletal or visceral. So from our primary survey, we went ahead to do a sample history. Our sample history revealed a number of things which we could use for our diagnosis. Unfortunately, we had another question, but yeah. So from the emergency conditions, we are supposed to identify what threats were in this primary survey, and from our assessment, initial assessment, we found out that this child was breathing at a rate of 38 beats per minute, which could definitely lead to respiratory fatigue. And our immediate action during this time was to give this child some supplemental oxygen. Then on the circulation, the heart rate was 148 beats, which is a tachycardia, and the capillary refill time was greater than 6 seconds, which is delayed, and this also pointed towards a shock, which could eventually become decompensated. So we started IV fluids, put up lines, and we started giving the child some IV fluids immediately. Then the cold peripheries and extremities pointed towards hypotensive shock, and definitely we took up some samples here and booked for blood just to be ready for transfusion. So this takes us to another discussion of the sample history. As we are stabilizing the patient, we did also gather more information about the patient. So in the sample history, the chief complaint was this child presented with a refusal to bear weight in the right leg for 2 days, and also had a progressive pallor for 1 month, and then restlessness and increased irritability and decreased activity. She also had pain over the right and tenderness over the right side, pattern bruising and conjunctival pallor. Allergies, she had no allergies. Medication, she had no history of regular medication. However, her last medication was a course of Coartem for malaria about 4 months ago. Past medical history, the child was born by SVD. Her vaccination was up to date. She had occasional uncomplicated malaria, and this was her index admission. Last meal she had had a cup of water and a cup of porridge about 3 hours prior to admission. The events that led to her admission is that the child had refused to bear weight on the right leg, and the mother reported that the child was clumsy and had an unwitnessed falling, and this had led to a lot of bruising and injuries to the legs. However, the auntie also reported that the mother has a boyfriend who likes using harsh disciplinarian methods, and the time when this child got these injuries coincided with the time when the child was with the boyfriend of the mother. So based on our sample history, I think our dear moderator again, you can have our discussion.
Yeah, thank you, Dr. David. What are the possible differentials and what will you be looking for on examination to support this? As we earlier said, feel free to respond to this discussion by typing into our chats. All your answers will be responded to by the presenter. You can continue, Dr. David.
So we went ahead to do our full secondary survey, a tutor examination. Generally, we did a general examination, and the child was irritable from the head. She was normal K5. The head was normal size and shape. No bruises. However, she had only 1 bruise on the right cheek. The eyes, she had no conjunctival hemorrhage, but she had conjunctival pallor. The ears, the confined membrane was normal. The chest was clear. The abdomen, there was slight gagging in the right upper quadrant. The black hard pattern bruises was really observed. And then when we examine the genital, urinary, and the anal area, because this is mandatory for any child who presents in this manner, we found the genital urinary system and the genitalia to be normal. However, the musculoskeletal examination, we found the sensations and the movements were normal for the upper limbs, though the right, she had bruises on the right thigh, and she would really be in pain when she tried to touch the right thigh. The neurological examination, the cranial nerves were normal. The muscle power and sensations were intact for both upper limb and the left lower limb. However, again, like I said, the movement on the right lower limb was reduced. We also noticed behavioral signs where the the child would become injured when the mother appeared and would become normal when the mother left the room. So what were our possible differentials? Given the picture that we are having here, this is really a broad history, and you can think of so many possibilities. Some of the things we thought about were sepsis, because even sepsis can present like this. Trauma or toxins, soft tissue injuries, fractures of the right femur, traumatic brain injury, mild traumatic brain injury, or non-traumatic injuries. We thought about hematological conditions, especially coagulopathies like Von Willebrand. We thought about thalassemias. Then we also thought about metabolic causes, which could present like this, especially iron deficiency. And we also thought about neoplastic conditions that present like this, especially the hematological malignancies like leukemia. So we went ahead to do a number of investigations, the baseline investigation mostly, and we did do an RBS initially, and then we went ahead to do a malaria RBT, which was negative. We did a CBC, where we found hemoglobin to be 7.2, and a number of deranged parameters like the reticulocyte and the R that we use, all these which pointed towards necrocytic hypochromic anemia. We ordered for an ultrasound, and then we also ordered for an X-ray of the right femur, and also a skeletal survey. And the child was found to have a mid-shaft fracture in the right femur. And also the child had healing fractures of the rib cage. So that's the X-ray. Abdominal ultrasound scan was requested, but the results were not given. So at this point, our impression was non-accidental trauma. Given the history and the presentation of this case, non-accidental trauma, specifically looking at physical child abuse with nutritional iron deficiency anemia, accidental trauma with coincidental iron deficiency anemia. But given the inconsistent history which we are having, I would rule out this. Then we thought about anemia of chronic diseases, and this was further investigated from the professional level. So our supportive management, immediately, we maintained the airway by positioning the patient in a neutral position. We gave supplemental oxygen, 2 liters per minute, and did continuous pulse oximetry. Then we started 2 large IV cannulas. We started maintenance fluids, D10, around 600 mils, which was 24 hours, and we were giving it at 25 mils per liter. And then we also gave saline, 550 mils over 24 hours at a rate of 23 mils per liter. Then we also splinted the right leg and immobilized it using the Thomas splint, and informed the orthopedic team. Going to the specific management of specific parts of the presentation, we managed the anemia with the transfusion. We transfused the child with packed red blood cells and pre-medicated with IV paracetamol. And we also monitored every 15 minutes for the first 1 hour, and then we monitored hourly. For the iron deficiency, the child was given syrup hemofort, was also given tabs vitamin C to enhance absorption, and then was also given tabs Benda's 200 milligrams tabs. And then for the fracture, child was given tetanus toxide, was given IV ampicillin 500 milligrams, TDS, and then the orthopedic team was informed about the definitive management and the post-body spark cast for the child. We sent the child to Ward 16 for further management and investigation, and we involved the multidisciplinary team, the psychosocial, the pediatric social worker was informed to carry out a psychosocial assessment of the mother and the auntie and the boyfriend. The orthopedic team was informed about the management of the fracture, and then the child safety. The child, we called upon the psychosocial team to help us in the safeguarding of the child, and the mother and the boyfriend were not allowed to see the child unsupervised. At this point, we also filled in the suspicion of child abuse form 3, and then also informed the administrator and focal person for child abuse, who took on the case, and the case was reported to the probation officer as mandated by the law. Thank you, colleagues. That brings us to the end of the in-hospital management, and I think our next part will be the pre-hospital management.
Thank you, Dr. David Mirumbi. That was a good case presentation. We appreciate you and the team for managing this child. The approach, right from assessment to the extensive intervention, was very good. This moment, before we invite in the pre-hospital care provider, we shall have like questions. I request 2 or 3 people to ask questions towards Dr. David's presentation on the case. By show of hands, the rest keep on typing your questions through our chats, or will be responded to by Dr. Gerard Ojambo. Thank you all. So far, we have 218 people on the call. Question towards the case presentation. Any question towards the case presentation? If there are no questions, just continue typing in through our chat all your questions and responses. At this moment, I'll invite Mr. Ntambi Umaru, hospital care provider and instructor with Apple, who is going to take us through pre-hospital care of crying and irritable child with suspected non-accidental trauma. Doctor, over to you.
Thank you very much, our moderator, but I'm also humbled that if you look at our presentation where we have started from, it should be ready for the pre-hospital team to wake you up that what is it that we really need to pay extra attention to. I mean, from our case presentation, you and me will agree that as pre-hospital, we have a lot as far as preparation, planning, and ensuring that you have it all. It becomes very, very important that if you don't do this, then the management, probably in one or the other, we might lose focus. So I want to interest myself by reminding colleagues that with this particular case, it'd be very important for you to look back on what are the stuff I have on board. The type of stuff you need to send out to pick the baby should be rhyming. When you look at the patient, today we have a baby, tomorrow we might have a neonate, the other day we might have an aged person. So it becomes important for us also to understand the patient and then your equipment. This is one of the key things that has actually affected us during the time of response. You packed everything, you reach on ground, the nature of prongs you have for the adults, yet you come for a child. So it goes back to the equipment. Think about your medication. What type of analgesia do you want to give to your baby? And probably if we go further in the line of pre-hospital, we still have the limitations when it comes to the medication. So what is it that I can do? Medication, number one, if a baby has temperatures, I want to make sure that either I observe them by saying if the extremities are cold, I want to cover. If the temperatures are high, I want to expose. I'll put it under medication. Then selection of the mode of transport. Let's agree that with this type of baby, separating the baby with the mother will be one of the disservices. But the mode of transport you probably brought on board. How are you going to transport the baby? Did you prepare your car in a manner that it can occupy or take care of that? Above all, documentation. We tend to be very busy and forget where we say it is not recorded, it was never done. In other words, we must record because at the end of the day, you need to handle. If we do that, then let's not forget that when it comes to dealing with children, the law is very clear. What is it that you saw? What is it that you really gave yourself to understand? So basically, our discussion is going to rotate around staff, patient, equipment, mode of transport, your documentation, and above all, the legal part. The legal part, where did you seek for consent from the parents? Or you think because you're the paramedic who has been sent to go pick the child, you should proceed and then have the patient. So I straight away go to the case. We are dealing with the same case where we have, this is the same case brought forward. We already have confirmed. So the question is, how are you going to have this? It is important that at the time of picking the information, listening attentively for whatever you want to do next, you should really embark, you should base it on all you want to do from this, the details from the call. What did the call say? It is saying it's a 3-year, let's plan and prepare for the child, okay? They are telling us 2 days back, there's been a problem with the child. Interest yourself in this environment. Maybe it is the reason as to why this baby is actually turning out to be a problem. Then you further shoot in by having a close look with this baby. What is it that you can see with your eyes? Yes, I am seeing the scratches. I am seeing the bruises. What do they transmit? What is it that is communicating to you? Don't just conclude. Probably the baby was insulted. What's your assurance that maybe you cannot become a victim in the few minutes when you're present? So we are saying that, yes, let's go ahead, understand what we are going to deal with, prepare appropriately, be in line. Don't expect less, please expect the worst with such incidents because it will help you to know even how to intervene. So we'll go further and then try to say, yes, I am now getting on board. Above all, no one can ever guarantee your safety. Personal safety should be accounted for by the individuals. Pre-hospitals, this is one of the areas we are turning out to be the areas of weaknesses. We want to save lives, but we forget that we need to come on board as number one. So your personal safety is important. The history is revealing somewhere, somehow there was violence with the child. Maybe even the adults at home were violated and you haven't confirmed to this because there's no report. What is your assurance that when you get there, you will not have this? So personal safety is important. We go an extra mile and be sure that we have it. Don't stop on PPE, your gloves and mask and everything. Go an extra mile to understand what is it that I might need. The scene, you're going to pick a child. It could be a home, it could be a health facility, lower. We are saying that go an extra mile to understand what is my safety on scene. I am going in a slum. It is totally different with an environment which is not in a slum setting. So in any way, maybe the community is already charged. They are tired. They have been calling us for the last 2 days. We are appearing today. It's not our fault. It is the time we have received information. So the scene can turn out to be violent, regardless of you wanting to come and probably give a hand. You're doing the right thing, but they don't know that you have just received the information because they have had this baby for quite long and they need you to come in. Look at the distance you've covered to pick out the child. It is also very important. If you went far and you have not also planned for this, what is the assurance that you'll come out safely? The other key thing that today we need also to factor in is the weather. Maybe you left when it was very okay. It has rained when you're down there in the community. You can no longer come out. Community has charged. They are saying, take the baby. You need to get out of here. So when we talk about seeing, let's not only look at what we are seeing here with our eyes. We need to anticipate. We need to think bigger out of this. What if it is this? How do we go out of this? And then lastly, we can close into the subject, which is the patient. It has been very commonly that when we go to respond, we straight away interest ourselves on the patient, but we are saying that the patient should come number 3 after ensuring I am safe, the environment I'm working in is safe, and now my case is the patient. Go an extra mile to have this patient. One key thing that I should also interest our members is that, yes, you're the person who has been invited, but you need to seek for permission. Seeking consent is important. Maybe the father of the family has said, no one touches my child without my permission. But because they've showed you that this is the patient, you go an extra mile to just receive the baby, minus the approval, because maybe he has confirmed, I need a verbal request. So you don't have this, then you go in, you're going to become a victim. They have just because you didn't really put in mind that, oh, I need to really seek for consent, regardless that this is the baby. Okay, yes, I am here. Is it okay for me to really go ahead and probably assess the child? Putting the child before it does not give you guarantee that this is clear, automatic, go ahead for you to go in. So when we are looking at the patient, after knowing what you have seen before touching, let's have permission, let's confirm that we have been approved, we have been given a go-ahead. And that is why we are saying seek consent. The parents are there, they're the ones who have called you. I mean, in scenarios, even while we are dealing with no one around, we go an extra mile to verbalize this statement such that I can have witnesses who will say, yes, but he said that, could he please proceed to assess the patient? So safety is so broad, so huge, more so when it comes to pre-hospital, and more so when you look at this case scenario, it gives us a lot silently. This is a violent home. What is the assurance that you're not going to be battered or probably become a victim? So look out for the safety, personal safety, scene safety, and patient safety before you could probably proceed with what you want to do. Key things you should never forget as a person. Yes, you're the responder. What do I have in mind? When I was setting up, who are the key people I have in mind? We are saying that the pediatric specialist is one of the key persons we need. And this will take us back to understanding that very important, we need to know where the child should benefit from. Okay? What are the symptoms? What is it that it is transmitting to me? Let's not take a child in a facility where the patient is not going to benefit. We should target areas where we know, okay, if I don't have the pediatric specialist, maybe there is another pediatric physician that I know of who is in this facility X. We would recommend that we go in for that. The history is revealing that the child has a fracture on our list could also propose to have this orthopedic surgeon. And we are zeroing down to say that maybe the pediatric orthopedic surgeon would play, and probably the patient would benefit more than the other versions. So we are saying that let's go ahead, zero down to understanding the needs of the child. We have the service providers. We cannot actually underestimate this. We align them in relation to the service that they need to pick at that time. This is where we do a lot of wastage of time. You go and start gambling around. Yet if we had hit it direct, the patient would really go an extra mile to benefit. We are seeing that we have cases of a patient not wanting to eat. The way we deal with adults is not the way we deal with children. I know Dr. Sabrina will emphasize on this when it comes to how it comes, why would the patient lose appetite? So we're saying that it is important to align our patients with where they will get the service, and that should be at the back of the mind as a pediatrician. I am picking, but I am going to facilitate X, Y, and not Z. We are saying, you who is dispatching the ambulance, information has been provided to you. Who do you want to send? In my opinion, I am thinking that if you have a pediatrician around who is good with emergencies, let this person be part of it. If it is me, the paramedic, I would love to specifically pick on someone who has dealt with children. It could be you have had experience in managing probably emergency pediatric in advanced life support. If it was a newborn, I would recommend a paramedic who has done maybe neonatal life support. So the personnel in relationship to response at pre-hospital is very, very important. For it will summarize, it will save us. But a scenario where you don't have, I still insist, let's have someone around the pediatric. This is a pediatric nurse. This is a pediatric specialist, someone who is good with children medicine. It will save a lot, and we will have this probably doing good for the little ones. And this is what we are looking for. So as we select personnel, maybe it is time for us to start preparing the pre-hospital teams in line with what we have. We could probably interest ourselves in conducting a number of surveys that what is the gap, what are the common cases we have from the communities, which will always also support, just to make sure that we close loop the entire system when it comes to benefiting the patients at that particular time. Again, you are responding to our 3-year-old. What are the equipment you must not miss? Like I already told you, this is a common practice. You know that the child has difficulty with breathing, but in your plan, you have not aligned the right gadgets. Definitely, when you go down to the ground, this is challenge number one. Look at when you want to take the BPs, what type of cuff do I have? Many of our bags are stocked with adult cuff, but I am going for a child, meaning that I am going to fidget around, and at the end of the day, it will come in. I've talked about oxygen delivery. You have prongs for adults, yet we can have prongs for the little ones. So when we talk of equipment, we are recommending that at this particular time, let's have the pediatric first aid kit on board above other things that we are stocking. Let's have them. When it comes to oxygen and the ventilation, we should not forget what are the delivery key equipments we need. We need the monitors because we have to give care on scene, in transit, until we get to touch base with it. So in this particular case, it would be very smart for the team picking the baby. One, not forget the pediatric kit. Two, the oxygen apparatuses, entire kit, but also our monitor should be aligned to give us the signals that we need. And above all, don't forget your thermometer. We know what weather does with children. We know how they change. Irritable, he's crying. A lot has changed. And then we'll start panicking. Avoid panicking, planning smart, have the right equipment. We are saying that quick assessment should be done. You have all this with you. Always be on top of the game. What is the air of my child? He's crying. Good. I have a +1. But then if I go an extra mile, if I want to really go an extra mile, is the crying of the child the one I am expecting? Yes, when I ask the baby, he tries to even talk to me. I give a credit. I assess my breathing. We've already been told that the child is not using effort to breathe. So if the accessory muscles are not involved in this, I don't have the granting, neither do we have the flare, really, I should not worry. But then I know somewhere, somehow, this is a baby for the last 2 days. I need to do something when it comes to the breathing part. So I want to deliver my oxygen, maybe somewhere, somehow, to better them and keep them, because we are going to move. It could be affected along our movement. So it should be very important. Circulation. This is where I am saying pre-hospitals, your tools are with you in your hands. This is one of the best things you're going to do. You have already gotten permission, have access to the baby. Please, I always tell my colleagues that if you remember the inverted J, feel the extremities. Are they cold or warm? You should know where you're headed to. Try to go to the capillary. What is it? Is it delayed? Is it fast? You don't need even a pulse oximeter. I'm going to go in. Then I need to feel the pulse. What's the pulse? Is it ready? Is it weak? I have only used my hands. I am in to tell that things are not very good with me and I need to plan my next move. So it becomes very important for us in this scenario. We are seeing that the capillary in one way or the other, it is still very stable. We should not worry. But you never know when you start moving, anything could come up. And when it comes up, how prepared are you? And what should you have at the back of your mind? The disability, what do you see with your eyes? Look critically. Yes, if it means exposing the baby, expose. I am seeing a swelling on the other arm. Attention, I need to do immobilization. There, then plan your immobilization. Do you have the right splits? Did you prepare adequately? I have them. Yes, it's going to be. When I look at the body, do I have any scratches? What can I see with my eyes? I need to pay attention to that. And then here I'll go an extra mile. Make sure that I make that quick assessment. What is it that I have seen to fix? And now in this case, the fracture needs to be immobilized so that probably in one or the other, the unnecessary movement is limited as we are preparing to dispose of this patient. Expose temperature, you felt in the extremities, but now you have the physical eye zone on the baby. What is it that is there? What is it that should not be taken for granted? Maybe at the back, he has open wounds. This is the time you can have room to look at it. Expose, remove everything on the body. Very quickly look, what do you see? This is what I've seen. Try to feel it, because the next step you need to is to make a handover. You need to have a report that is actually awaited for where you're headed to. It could begin one with a phone call where people need to understand that, okay, we are coming in, but this is what you should expect. And we are recommending that if we use ISBA, it would be the best. And here we are saying that it is important. What have you been able to identify? Tell us, yes, I am handling a 3-year-old patient. 3-year, okay, what do we need to prepare? You're telling the ED to now prepare for a 3-year-old. You really need to know the situation. This is a patient who is presenting with the irritable crying, and he has actually refused to bear weight. Somehow, I am telling you the baby has a fracture which has been immobilized. Orthopedic surgeon needs to be on standby. This is what we are bringing in. We are talking about a baby that has been in the community for the last 3 days. This is not good news. We go in, yes, what is in the background? The home was a bit violent. We think we are safe, we shall be out, but there was some violence on the child. In one or the other, it could not come out very fast, and then we will be in very good. And then assessment, what are my key findings? Very above all, and then what is your recommendation? So as pre-hospital, this is the time for us to remember that, yes, everyone has a task. but whatever you're presenting at this level means a lot when it comes to how best the baby is going to benefit. Unless otherwise, moderator, I am not sure, I might have surpassed your minutes, but it was important for the team to receive the handover. Thank you so much. Back to you.
Thank you, Mr. Ntambi Umaru. That was a good and elaborate discussion. You pointed out all the points that the audience needed to know. Issue of course, safety, equipments you need to know, then the personnel. Those are all points. Then the ABCD approach and handover. Those are all points to remember by the audience. At this time, I request like 2 questions from the audience towards Dr. Umaru's discussion. As we continue typing in our questions into the chats. This moment, I see we have so far 258 people on the call. Thank you all. Any questions towards Dr. Ntambi Umaru's discussion before we proceed to the next presenter? Yes. Yes, we have Ocheng Robert. Kindly unmute yourself and ask your question. Ocheng, are you there? You can unmute and ask your question. We can't hear you. Unmute. Unmute. Ocheng, are you there? Okay. Let's proceed. At this moment, I'm going to invite our next presenter to take us through the acute care assessment, investigations, management, and medical legal consideration and disposition plan for a crying and irritable child. We have Dr. Sabrina Chitaka, Senior Lecturer and Honorary Senior Consultant Pediatrician, Makerere University and Mulago National Referral Hospital. Dr. Sabrina, you're most welcome. Over to you.
Thank you very much, the moderator, and many thanks to the EMS ECHO and SEED Global Health for inviting me to be part of this presentation and a very interesting conversation. I'd like to thank the previous presenters because they made my work really easy. Next slide, please. So I'll be talking to you about the approach, previous slide, please, of a crying and irritable child. And as someone had asked in the presentation, what's the difference between crying and irritability? We all know that we are born crying. And if you don't cry, the doctor actually slaps your feet to make sure that you cry. And also when people die, people cry again. So we are all conversant with crying. There's a release of watery fluid from your eyes. So that is crying. But irritability is a sense of inconsistency and annoyance or anger. And many things can make a child irritable. Next slide. So oftentimes you'll see a baby saying to you even, you better figure out why I am inconsolable, or I'm going to give you something to cry about. It's not unusual for a parent to call and say, Doctor, my child is crying and I cannot sleep. Even just 2 days ago, a doctor who recently had his firstborn baby called me and said, my baby is crying. She has not made a poop in 5 days. And after having a good discussion with a young doctor and his dear wife, we figured out that the baby had constipation and bloating and eventually colic. Next slide. So without a question, one of the most challenging tasks in a life is to raise a child. And the degree of difficulty of this challenge is heightened when the child becomes inconsolable. Inconsolability means that the child, even though you cuddle them, even though you sing to them, even though it's the father's voice or the mother's high-pitched voice, the baby continues to cry. And since a young infant or child has very limited repertoire to convey illness, constant crying needs to be taken very seriously by anyone working in the emergency department. So I'd like to thank Dr. Mwirumubi for sharing a very important case that highlights to us the importance of looking again, making sure you understand why is this child not continuing to be consoled. So before you jump into the usual, it's merely colic, probably colic. In a 2-month-old baby, for example, there are things that you need to have on top of your diagnosis or your differential diagnosis when evaluating a child who cannot stop crying. Next. So colic has some criteria, and I want you to understand that colic is the pain that comes from the baby's gut when the baby has learned how to feed, and because the baby is for the very first time learning how to pass the food from the mouth through the gut, through the anal canal, it can be a bit difficult. Some people think it's muscle aches. Some people think it is the gas in the abdomen, but whatever it is, colic is extremely common. Nearly 1 out of 3 babies will experience colic, abdominal pain, and we have names for it. In my language, it's called owoka, and in other languages, I'm not sure, but it's that pain that is continuous when baby cries for more than 3 hours a day, or more than 3 days every week, or has more than 3 weeks in duration of crying. Colic can begin as early as the 2nd week of life. It peaks around the 6th week of life and should have resolved by about 4 months of life. But in pediatrics, we say diseases don't read textbooks. Children can continue to have colic even until 6 months. There are various characteristics of young mothers which are common in this country, especially because 1 out of every 4 girls is pregnant before the age of 18. So little education, rural dwelling, poverty, marginalized. So when Mr. Umar goes to pick up a child in a rural dwelling or in a marginalized community in the slums, they should know that one of those babies could be born to a mother who is poor, little education, and crying inconsolably. Next. So the moral of this morsel is a thorough history and physical exam is needed, and it is going to be the best tool to help you determine the cause of crying. Like you've heard already, be diligent. Pry open the mouth, look inside the diaper area, examine each appendage, and appendages mean the fingers, the toes, the ears. Examine the hair. It could be that this child has lice. Do not be in a hurry to diagnose colic. Next slide, please. We know that every child should not only survive, but they need to thrive and grow up and transform their society. So for a child who is crying, it could be anything, as we are going to see, from infections to colic to trauma. But whatever you do as you examine this child, make sure that this child not only survives, meaning that the child could have meningitis and get a seizure and then does not thrive. And as you ensure that this child thrives, you've gone through your ABCDs, make sure that this child that you're saving or responding to is going to be able to transform their society. Next slide. So these are helpful mnemonics, and I like mnemonics, as many of my students will tell you. So it cries does not mean it is a kid, but it cries. So I is for infections. It could be a urinary tract infection. It could be meningitis or sepsis. And all these things can make a baby fussy or cry or be inconsolable. It could be trauma. The baby could have had shaking baby syndrome, that the mother or the father picks up this baby and shakes this baby. And the child could have fractures like the one that was discussed in the case, or non-accidental injury. For the T, be very sure that you exclude non-accidental trauma. And then for cardiac disease, it could be anything from congenital heart disease to acquired heart disease. And then the R could be a reaction to medications or reflux, or it could be that the child has developed an anal fissure if they have constipation, or the child could have intussusception because they have intestinal obstruction. And then for the eyes, it could be a corneal abrasion, foreign body or glaucoma. And then the S is for strangulation or surgical processes. And in here, I'd also like to add for the S, ovarian or testicular torsion. Next slide. So for an inconsolable child, it's very important. I understand that the slides are not moving. Would you, in the room, could you reshare the slide? Because the slides are not moving. I can see the slides moving. So let's proceed. For an inconsolable child, it's important to examine the child from head to toe. For the head, you want to see if the child is conscious. Do they have a full fontanelle? Do they have a space-occupying lesion? Do they have lateralizing signs, which could mean that the child has an infection? Is the child bleeding at any part of the brain, that they had a head trauma? And then for the eyes, you want to look inside the eyes. Is there bleeding? Is there a subconjunctival hemorrhage? And then has the child scratched their face or the eye? A lot of times mothers delay to cut off the baby's nails, and the child could injure their eyes and cause an abrasion. And then also the child can develop glaucoma, and it's not impossible for children to have glaucoma. It's important to look inside the ears. Babies with acute otitis media or a retained foreign body, they may have an overvigilant assistant parent who is a 3-year-old sibling who pushes something into their nostrils or into the ears. Next. So what about the mouth? The mouth is like an open window. It's important for you to look inside the mouth. The child could have a rash, they could have oral thrush, they could have a strawberry tongue that could indicate Kawasaki's disease. And we know that Kawasaki's disease presents with a very high temperature. And then the baby could be dehydrated. There are these overvigilant mothers who overwrap the baby, making the baby extremely hot. And yet we live in a tropical environment where there's no freezing. But also on the chest, look and feel if there are any rib fractures, if there's a pneumothorax, if there's a pneumonia. Does the baby have fast breathing? Do you have your stethoscope in the ears and you're listening out for crackles or even rhonchi? Next. Then the heart, it's important to listen carefully, first by taking a pulse and then listening to whether there are any dysrhythmias or if there are any murmurs for congenital heart disease. somebody is asking me to simplify what is Kawasaki's disease. It's an autoimmune disease that happens after a viral illness and typically presents with a high-grade fever, strawberry tongue, and coronary artery arthritis. It's a diagnosis of exclusion, and it includes us doing a full blood count and then doing D-dimers. As I continue in the abdominal exam, it's important to palpate the abdomen, ensure that there is no urinary tract infection. Abdominal exam in a baby is not complete until you do a pervaginal or perineal exam, because you may find that the baby has a discharge or has a tear. There are people who are violent and they could have abused this child. Examine for masses. Is there a liver? Is there a spleen? What is causing pain in this baby? And when I talk baby, I'm not saying a newborn baby per se. Baby may mean anybody from 0 to 18 years. And then for surgical procedures or complications, it could be intersusception. Do a finger exam in the anal area. And if the stool comes out and it looks like jelly, that could definitely mean intersusception. What about appendicitis? The pain is pointing and there's tenderness, and also there could be bowel perforation, but a baby who has a perforated bowel is one who is extremely sick. We know that babies can get enteric fever and bowel perforation, but also they can get Hirschsprung's disease, where you have a ganglionosis, and that, yes, baby is 0 to 18 years, but also I know that adults in this room are being called baby by their dear ones. Next slide, please. So look in the diaper area. A baby who has testicular obstruction or torsion will have reddening of their testicles, or if there's an incarcerated hernia, or if the hair, for those who have very long hair, that the hair has tied up the testicles, or if the baby has an anal fissure. And then don't forget, we live in a place where sickle cell disease is really common. 1 out of every 20 people in our setting has the sickle cell trait, and the likelihood of having sickle cell crisis is also high. What about septic joints or post-vaccination? And I am a vaccinologist. I know that many mothers will call you saying, my baby was vaccinated and the baby is crying profusely. I usually tell them, swaddle them, calm them down, make them have a warm, tepid bath, but please don't give paracetamol. For the skin, look at the skin in totality. There could be a rash, a pimple, a bruise, or the baby could be bleeding with petechia and purpura, or it could be an entire toxidrome. I shared this picture of an image of X-ray. And remember, some fractures can be because of non-accidental injury, or the baby could have brittle bone syndrome, or osteogenesis imperfecta, or low iron vitamin D deficiency. And so it's important for you to be able to ascertain that there's no green stick fracture or multiple fractures in this child. Next slide. So there are common things and there are benign causes. Of course, we know crying is a way of communication. I'm talking babies who cannot talk back to you. There are basic needs like hunger, thirst, a wet diaper. If the baby is feeling very cold or feeling very hot, especially if you've wrapped them with all the clothes that the grandmother, the auntie, the in-laws gave you, baby will feel very hot. And then there's discomfort like gas. If you don't burp the baby after breastfeeding, teething can cause a lot of irritability. That the irritability can be because of the clothes or some food that you're giving the baby. I know babies who are now allergic to peanuts, and if mom is eating peanuts, then you're likely not to get, you're likely to get a child who gets some rash or irritability. I know that it's normal for an infant to cry, and crying is an extremely normal way of communication. But if a child cries frequently, repeatedly for more than 3 hours, continuously, and even fails to feed, that should be a reason for concern. Why shouldn't we give paracetamol to babies after immunization? Because the fever is a way of demonstrating that the baby is actually getting the immune response to the vaccine. Thank you from Gerald for answering our IT warrior. Next, please. So infantile colic means there are episodes of unexplained crying that don't have a clear medical cause. Reflux, which we also call GERD, is because the baby has irritability, particularly to acids, or even if the baby has constipation, has not passed stool for a while. And this can even happen to older children. And then obviously food allergies. We need to understand that food allergies can cause fussiness. Some babies are allergic to milk. They are lactose intolerant, and then you keep pumping them with the milk, and then also you're giving them peanut, which they are allergic to. So you have to be careful around if your baby is given a particular type of food and starts to cry. They are explaining to you that, girl or dad, this is not the food I need. Please find other types of food. Next. There are serious causes that we must rule out, and I already talked about these, including urinary tract infections. We know that baby boys are more likely to have urinary tract infections below the age of 2, while girls are more likely to have urinary tract infections later on because of the way the butt is wiped. In surgical emergencies, I already mentioned intussusception or even an incarcerated inguinal hernia. Next. So we've seen all this. I'll skip this, please continue. But I'd like to emphasize that when the baby continuously cries, you need to exclude a non-accidental injury. A non-accidental injury can be because mom is depressed, and we usually use the Edinburgh postnatal depression scale to ascertain this. And when should you be concerned as a parent? You know, I know babies communicate by crying, but when should we be concerned? If the temperature exceeds 38 degrees, if the baby cries when they are moved or held, meaning that there could be a fracture, if the baby starts to vomit, if the baby refuses to breastfeed or drink for more than 8 hours, if you see any swelling or rash or lethargy, that the baby is just floppy and not moving, is not the happy self, mothers would know that this is not the usual baby. And if the baby's concerns include their health or safety, if the baby is not able to cope, or if the mom or the dad are not able to cope, because we know that if the suspicious parent is one who is less than 20 years, dad who's not working, dad who takes lots of alcohol, that is a dangerous place to live in as a child. And also, if you walk into the room and you see that the room is shabby, it's unkempt, then you know probably there's something more than meets the eye. Next. So I'll quickly talk about adolescence. And the first image, which I shared with my family, and my husband was like, why are you showing them a very tiny little a woman? And that woman for me represents a woman with anorexia nervosa, a teenager who completely denies any relationship with food. That is anorexia nervosa and needs to be investigated. A person who carries their feet on high-heeled shoes for over 6 hours is likely to become irritable. Whether they are a teenager or a mom, they are likely to be irritable. What about broken relationships? All these can result in non-accidental injuries. Next slide, please. So we know that adolescents are not big children and they are not small adults. They're a special group of people and we need to reach out to them. They are going through a transition from being from child to adulthood. And so even as we save children in the neonatal period, under 5, we've improved on our under 5 mortality. We've ensured that children in Uganda are vaccinated. They are growing up. We should not forget children in their second decade of life. Next. And when you see, next slide, when you see an adolescent crying, especially many of you who may want to do adolescent medicine or sports medicine, please examine them fully. They could have had a fracture, they could have muscle tears, or even in the long overhaul, a heartbreak. And crying in this situation may mean various things. Next slide. Whatever we do, we need to understand the 10 most common causes of death among adolescents, especially by sex, which includes number 1 on top of our list, road injuries, infections such as HIV and AIDS, self-harm, which may mean poisoning, which is intentional, and then lower respiratory tract infections, personal or interpersonal violence, diarrheal diseases or drowning, and then meningitis and epilepsy, and then other endocrine problems, including diabetes and blood and immune disorders, which they could have been born with, and the crying could have started earlier on, but then it persists throughout adolescence. Next. So what exactly am I saying? In whatever we do, we have to promote safety. I borrowed this picture from the New Vision page. And honestly speaking, for you to carry your entire clan on a motorcycle without helmets is dangerous. Imagine the little baby at the end could easily fall off this motorbike, could easily injure themselves, and then they could come into the emergency room with pain and crying and a fracture. Next slide, please. So for what we have understood and learned throughout the whole 2 hours, and I'm sure that some people are already exhausted, the differential diagnosis for an inconsolable infant includes basic things like hunger, discomfort, fatigue, or even common medical issues such as colic, reflux, or constipation. But there are more serious things that range from urinary tract infections, sepsis, or surgical emergencies like intestinal obstruction, or even common issues like food allergies, hair tonics. And if you forget everything else we have said, please make sure you do a thorough physical exam. And before that, take a detailed history. Understand the socioeconomic status of the parent, and also look out for red flags. Not red flag, but things that would point you into suspicion. And we all need to be like investigators. We need to watch out for the things that will help you to establish or rule out non-accidental injury. Next. So this is a quick, and I'm not going to go through all this, but if you see a child who suddenly starts to cry, if there's no presence of injuries or concern for head trauma, if there's no concern for underlying medical causes, then start to screen the mother for depression. If there's a history and examination consistent with a child who is normal, then you want to do parental reassurance and education and focus on a decision to have a multidisciplinary team support the child. If, however, the baby suddenly starts to cry and then is unwell, you want to look for things such as the ones that I listed before, infections, that it cries. Is it an eye? Is it the bones? Is it the skin? And then if there's presence of unexplained injuries, please rule out child abuse. Child abuse is more common than we imagine. And child abuse can be because of a family that is disgruntled, a family that is using sexual and gender-based violence. And then also, if there's a medical examination, try and look for the actual cause. Diagnosis includes a thorough physical exam and then investigations. Investigations from doing ruling out infectious causes, ruling out metabolic diseases, ruling out endocrine disorders, and making sure that you treat them. In all that we have said, facilitate urgent assessment and support of parental mental health. Mental health is a big, big thing. It's a big elephant in the room. And mental illness does not necessarily mean that, you know what, parents are dropping their clothes off and being irritable. It could be a parent has anxiety neurosis or has a panic attack and has slammed the baby against the wall. And like you heard from our case that Dr. Mwirumubi discussed, that dad was the one traumatizing this child. Next slide, please. So I'd like to sincerely acknowledge EMS ECHO and SEED Global Health, as well as the Department of Pediatrics here at Makerere University. I usually teach the unit that talks about child abuse. And I'd like to promote that we must say no to corporal punishment. Thank you very much. Over to you, the moderator.
Thank you very much, Dr. Sabrina. That was an excellent discussion. During Dr. Sabrina's presentation, he pointed out key important points to put into consideration while managing these children, issues of history taking, examination. He also brought out us issue of safety, screening, support, and others. Dr. Sabrina has interfaced or managed these children for over years. So she has a lot of experience in managing these children. Thank you very much. At this moment, I would still invite a few questions from the audience. I can give opportunity to people to raise up their hands and ask questions towards Dr. Sabrina's presentation. And meanwhile, let us keep on typing our questions through our chat. We have Mwembezi. We have Mwembezi. Kindly unmute Mwembezi.
Okay, thank you, today's moderator. I'd like to thank Dr. Sabrina for good presentation, and my question is rotating on a vaccinated child who has just got a shot. Now, what should a mother do after her child has been given a shot and develops high fevers? Then secondly, there is this problem in the community that we encounter, whereby most people are actually being driven to be using drip water and Bonsan in a case of treating the colic pain in their babies. How best can they be advised to on the use of these syrups? I thank you.
We have another question to Dr. Sabrina by Jonas Handubo Komati. Can kindly unmute yourself and ask your question.
Good afternoon. My name is Jonas, all the way from Namibia. Thank you for the presentation. I really don't have sort of a question, just a comment. And this is pointing to the challenges in the community of us, the parents who first seek traditional healers instead of bringing the babies to the hospitals and things like that. I'm not sure if it's the same thing outside, but it's one of the most challenges. So what could be the best advice? Because I know these things are cultural grounded. People first believe into seeking traditional healing before they come to the hospital. The moment they come to the hospital, it's already late, and we tend to see the children's perishing because of these delayments in treatments. What approach could be best be taken maybe to deal with such incidences? That is the first one. So the second comment I wanted to make was for the first presenter. I think I did not recognize my hand by then. And I just also wanted to, it's just an addition to us as a healthy care providers that we tend to rely so much on our minds and forget to have the helping aids when it comes to the treatment of being the children's or being the adults. So we should develop a habit of having aids like chats that can help you to remember certain stuff because you end up omitting certain important steps in the management of patients because you rely on your mind, but we are aging and things like that. You might not remember everything. So you should try to have those helping aids. They are really helpful. And that is my submission. Thank you.
Thank you all for the questions, which will be responded to by Dr. Sabrina, then Dr. David for the second question.
Thank you very much for your questions. I'd like to thank Dr. Ojambo for continually responding to the chat room. First of all, for a vaccinated child, I want all of you to remember that the different vaccines that are given to babies start from day 0, with hepatitis B birth dose, BCG injection, and then polio 0. And as babies grow, they are giving more and more vaccines. In Uganda, we are now giving 12 different molecules, some of which may include giving about 4 injections, intramuscular, intrathecal, etc., to a baby. And there's been a lot of misconceptions surrounding when your baby is getting their vaccines. Mothers even go and purchase paracetamol, ready to give the paracetamol before the vaccine is given. My advice to all of us is let us not encourage mothers to give paracetamol before the vaccine. I understand a needle prick is scary and it is painful, but I also want people to know that those injections are not like as big as a cannonball, that they are going to create a big fat hole in the thigh of the baby. I think the parents are the ones who are more scared about the injections and the pricks than even the baby. A lot of times the nurses and the midwives and the pediatricians use the smallest gauge of needle to vaccinate the baby. So the fear may be with the parents actually. And I know that there may be a little fever that rises, and I'd like to tell parents, when the baby gets a fever, that's a plus, that's a positive thing, because the baby's immune system is functioning and taking up the vaccine. So please do not give paracetamol. The only reason you would give paracetamol is when the temperature goes beyond 38 degrees. But a little temperature rise of 0.3 degrees shouldn't worry anybody. The other thing is, please don't overwrap the baby. Do not swaddle them with blankets, t-shirts, the father's shirt, the father's trouser, a bed cover which the grandmother gave you. Please don't swaddle the baby. Let the baby aerate and cool down, but also hydrate the baby. When the baby is vaccinated, make sure baby breastfeeds enough. Hydrate the mom so that the baby has enough breast milk. And remember, breastfeeding exclusively is up to 6 months, and then we supplement. The other big question and discussion was on colic. What should we give when the baby has colic? There are a lot of herbal concoctions that have been given. Like my colleague has mentioned, there's no clear way that colic would be treated. Giving Bonisan or some alcohol in the gripe water is going to sedate the baby temporarily, but then the baby will wake up and cry again. So it's important, especially to counsel the fathers, that babies actually cry. It's usually crying baby, irritable dad, irritable mother, and the whole house becomes a whole fireball. So counsel the mom to be able to breastfeed the baby and then remove the air. And I usually tell parents that share the roles. If mommy wakes up at night and breastfeeds, she should hand over the baby to the dad so that the dad removes the air, so that it's a shared responsibility for the gains you have received. And then thank you very much, Dr. Handubo from Namibia. That was a great point on traditional practices and cultural practices. In Uganda, yes, we also have a lot of traditional healers, and I know that many parents first go to a traditional healer before coming to the hospital. I know babies who have come to us and they've had false tooth extractions, which we call evinyo in my language, and also in some cultures, the traditional healers actually use sharp objects and scarify the child's chest, which in the Western language is called oburo. Like they tell them they are removing millet grain from the baby's chest, when in fact they are removing pieces of muscle. So as you examine this child, it's very, very important to look out for any cuts, any abnormal bleeds, let's say on the gum of the child, because that could have inflicted infection and even trauma. So I hope I've responded to the questions that were asked. I'll let Dr. Mwirumubi respond to the question he was also asked. Thank you.
Thank you, Dr. Sabrina. Over to you, Dr. David.
Oh, thank you, dear moderator. Thank you, Dr. Andugo from Namibia. We are glad that we have people who are listening in from all that far. To respond to your question about AIDS and gates, it is very important to have the gates and AIDS because they really improve the efficiency and effectiveness in which we manage the cases. But also we can't do away with the fact that we also work in environments that are so resource limited, and sometimes omissions can happen, especially if you don't have certain resources. Sometimes when you're dealing with cases of child abuse, you're going to have to really probe, and you have to know that you're dealing with adults who might sometimes hide information away from you, and you have to really go ahead and look at all the inconsistencies, because they'll be pointing to these flags that you are supposed to look out for. But importantly, AIDS are very important, and I think this is one of the key steps that all hospitals are taking up, because currently in Uganda we have pediatric protocols, we have ACLS protocols, and all these are being incorporated in our emergency settings. Thank you.
Thank you, Dr. David, for responding to that question. At this moment, if there are no more questions, we shall move to our discussion, where I'll invite our Dr. Ojambo Gerard. Dr. Ojambo Gerard has been responding to the chat questions. Doctor, kindly unmute yourself and introduce yourself to the audience. You're going to point out key questions that were asked by the audience for discussion. Thank you. Dr. Jambo Gerard, kindly unmute yourself.
Hello?
Yes, we can hear you.
Yes. Thank you for the opportunity, for the moderator. Thank you very much for the discussion, dear experts. I want to highlight some of the questions that we've had in this session. Most of the questions actually rotated around the case. Well, most people wanted to know in this case why was this baby transfused? Why are we transfusing a baby whose hemoglobin is 7? Why are we giving tetanus toxoid to this baby who did not have did not have an open fracture? So, yes, since I was not part of the team that took care of the patient, I just thought the blood transfusions should be individualized. You may have an HB of 7, but if there is evidence that actually you are bleeding, like in this case, we didn't know if since this child had a fracture of the femur, there could be internal bleeding. You may find that you actually might still need to transfuse. And also, someone asked, why was the HCT, the hematocrit, not suggested? Not checked. I think must have been checked in the CBC, but it was not displayed. And that is one investigation of parameter that would actually show you a baby who is actually actively bleeding. All the presenters are free to actually comment on these cases to elaborate more. Then another key question that was asked was, yes, this is all easy to manage in the setting where we are. That is, I think, in the National Referral Hospital. But how would this treatment change if you are, for example, handling this baby in say, for example, a remote setting, a remote area, upcountry? How would you go about the management of this particular case? So I think the presenter there, you probably answer that. I wasn't able to answer that. The other question was how this is now to Dr. Sabrina. How does depression affect the baby? Depression in the mother affect the baby? I thought the answer was too long and probably need more elaboration. So maybe you will answer the group regarding that question. A few other questions were to do with reporting the case to the police. Yes, and maybe this also should be highlighted in the event. Why was this case reported to the police? Yes, it was, but I think emphasis should be put on the protocol. Maybe I will stop at that and let the presenters answer those particular questions in detail. Thank you.
Thank you, Dr. Gerard. I think the presenters have heard. We shall start with the case presenter, then later, Dr. Sabrina. Dr. David, over to you.
Yes. Thank you once again, our dear moderator. I will start by looking at the question about transfusion. First of all, we remember when we look at our vitals, this child presented with a tachycardia of 148 beats per minute, and also presented with a blood pressure of 92 out of 50. I know for pediatrics we have different ranges, but usually in our emergency settings we use something called stroke index, which can be adjusted for pediatric settings. So for this particular case, a 3-year-old, when we are looking at these vitals, when you calculate the stroke index, it came to 1.2, and this actually pushed you to almost someone who is almost going into hypovolemic shock. And that was one way in which we started fluids. And also after looking at the HB, we decided that this patient would specifically benefit from a transfusion with PAC. To comment about the hematocrits, I think it was there in the presentation, and it was 1%. So basically, when you look at that CBC which I shared, the picture was of a normal chronic monocytic anemia. And this really pointed to iron deficiency for us. And that is why we went ahead to supplement with iron. And again, someone asked about the TT. Since we had a fracture, and the patient also, when you look at the temperature, the temperature was 37.5. Again, we thought that giving TT would be prophylactically indicated, because we would be preventing tetanus in such a case. And another person went ahead to ask that how would you manage such a case in low resource settings? In low resource settings, you may not have all the equipment that is needed. You may not have all the personnel, but it is important to know the protocol of reporting. And it is also important to know that you can always refer to the next level. So if you are in a village setting where you are unable to do splinting or casting, but these are basic emergency things which I feel like at least even the most basic health facility can do some sort of splinting of a fractured limb, and then you are able to call in or transfer the patient to the next facility that can take care of other complications that arise. The reporting protocol, or someone asked about whether the case was reported to police. Yes, the case was taken up by the administrator and the child safety focal person of the hospital. Form 3 for suspicion of child abuse was filled, and the case was reported according to the law, and was taken up by the probation officer who is in charge of child abuse. Thank you.
So maybe just quickly to elaborate a little bit more on maternal depression. I want all of you to know that pregnancy and childbirth are two very major events that occur in any woman's life. And being pregnant is associated with a lot of hormonal imbalance, discomfort. You cannot imagine a baby growing inside your womb and you're growing bigger, your body's becoming shapeless, etc. And despite all the baby showers and cuddling that you may receive, it can be a form of discomfort. And then laboring or going through the delivery of a baby can also be extremely traumatizing. So we know that when a mother gives birth to a baby, there are intense changes in a woman's life, including the responsibilities. For somebody who has been walking around with her baby in the abdomen to now having a young life that you have to support, human beings are the only animals that depend on their parents until they're about, 5 years of age. We are not like elephants who are dropped out of this big animal and then you start looking for where to run. So the human baby is very delicate. And this can cause depression in some women. And postpartum depression has been equated to major depressive psychosis, according to the DSM-5 even. So there are tools that can evaluate a woman for depression or postpartum depression, which occurs up to the age of 6 weeks when puerperium ends. So it's important to look out for a mother who is detached from her baby, a mother who is irritable and not caring about the baby. And the babies can feel that disemotion. They can feel that the mom is sad. They can feel that the mom is not caring. Maybe she herself is not taking care of the baby very well. And maybe the concentration towards the baby is reduced. And as the depression sets in, if it is not identified or treated, the mom can become violent. And we've had cases of infanticide. We've had cases that have been described in literature of child abuse, including the shaking baby syndrome that has been well elaborated. And if they are with a partner who is also abusive or angry, they together can harm the child. There's a case that was described recently on a BBC documentary where this couple abused their child. The child was removed from them. And then when the baby was returned to them at the age of 3, they continually beat up the child until the child died. When the social workers came into the home, they found a very unkempt house. The couple had been drinking and smoking weed, and clearly they were not taking care of the child. We've had a patient who we treated for acute poisoning. The child had organic phosphate poisoning, and this had been induced by a mother who was worried that the father in the house was not the real father. So she repeatedly poisoned the child, and sadly, on the 3rd occasion, we lost that child. So as we work on child abuse cases, we have to have a multidisciplinary team. And I really hope that Dr. Mwirumubi, the social worker who is the case support on this child, is actually following up the baby. Because if that baby is taken back to these parents, they could end up killing the child. Remember, we want every child to survive, we want them to thrive, and we want them to transform their society. Thank you.
Thank you so much, Dr. Sabrina and Dr. Mwirumbi, for responding to the chat questions. Any other questions that we need the experts to respond to? Dr.
Yes, I still have.
Brad, yeah.
I still have. Sure. 2 more questions here. On a lighter note, I cannot give the answer to this, so maybe Dr. Sabrina will. Why do babies cry before they go to sleep? And then there's another very long one that how best could we apply the health belief model to address the challenges that the caregivers face when dealing with irritable children, in brackets, traditional practices, and reducing the risk factors that predispose to the above discussed causes of irritability?
Over to you, Dr. Sabrina.
Okay, I'll answer the easier question. Why do babies cry when they are forced to sleep? I think that babies sleep a lot when they are in utero. They are sleeping most of the time. And when the baby is born, a newborn babies can sleep up to even 22 hours if they are not woken up. Because remember, they are growing up, they want to be in a place as if they were in their mother's womb. And all the work they are doing is smiling, waking up to feed. They're like, a princess who is the sleeping beauty queen. So maybe when we try to force them to sleep on our terms, they want to defy and they cry. So you're putting them to sleep and just chucking them into a bed is not going to work. I think it's important for parents to be patient. I think one of the most big thing that taught me patience is being a parent. And I personally am a parent of 5 babies, the youngest of whom is 19. So when I talk these things, I really understand what I'm saying. Remember when you were a little baby and you were told, go and sleep. Not many of you wanted to sleep, even when you were about 8 years old, and your parents told you, please go and have an afternoon nap. You started to feel like, oh, you're being defiant. And lo and behold, when you became a teenager, sleep was even eluding you even more. people are more likely to want to watch television or be on their phones watching TikTok videos, some of which they made, some of which they did not. And they are really wanting to not sleep. But guess what? When you become older, you're going to want to sleep even more. The things that you hated when you were little will start becoming medicine for you, and that sleeping will be a luxury. So train the children to sleep and routinize them. And by routinizing the babies, it means that you should be a role model. When you say that sleep means 8 p.m. in your home, turn off the lights, please turn off the lights and turn off your community phones so that you actually sleep. Don't lie to the child that you're going to sleep when you're busy fidgeting with your community phone and the child is hearing the clicks. So when you sleep, really, really sleep. And as the baby develops a routine, they will learn that sleeping is actually a good thing. The other one was on health belief model. I'm not going to go into that, but I'd like to say that whatever recommendations we make to parents and to families, they should be within the confines of their capabilities. If I tell a mom who does not know how to read that please pick up a storybook and read to your baby, cuddle them to sleep. If I tell a dad that sing to your baby when the father is of speech impairment, how are they going to sing? So it's important to respect whichever family you're talking to and dealing with so that you work together. You're a team. You're not God. You're not being prescriptive, but you're being advisory. Thank you.
Thank you, Dr. Sabrina. Doctor is as well talking from experience. Of course, that is good. Dr. Gerard, do we still have more questions to the presenters? If there are no more questions, we have a few minutes to closure of the session. At this moment, I invite key messages to the audience from the presenters, starting from Dr. Gerard Ojambo. Dr. Gerard Ojambo, we did not introduce you earlier, you're a pediatrician from Masaka Regional Referral Hospital. I just wanted the audience to know.
Thank you very much, moderator. Sorry, I forgot that part.
Okay.
Yes, I am a pediatrician, senior consultant pediatrician, Masaka Regional Referral Hospital, and neonatologist. So, but for the message today, I see we actually have to I think be vigilant in when a child actually, we have an irritable child, we need to dig deeper and establish what is actually happening, not take anything for granted. Thank you.
Thank you so much. Next, Dr. Sabrina, key message to the audience.
Thank you very much to the moderator, and thank you everyone for listening in. This for me is a great discussion, and it shouldn't stop here. It should go out, and we should all be brand ambassadors and champions for child health. Children are precious, and it's up to us to ensure that every single child that we interact with lives in a safe environment. For a baby who cries, please know that it's not about you, it is about the baby. And if a baby cries for more than 3 hours, please visit a pediatrician, not a traditional healer, but a pediatrician. Thank you very much.
Thank you, Dr. Sabrina. Dr. David, key message to the audience.
Thank you, our dear moderator, and to everyone who has been listening to our presentation. My key message is that we have to be vigilant, and to the clinicians, you have to be thorough. You have to really take interest in knowing the kind of case you're dealing with, because sometimes the signs and symptoms of child abuse are really subtle, and it is very hard to establish that this actual patient you're dealing with might have been abused, because abuse sometimes might not be really physical, but could be emotional, or it could even be spiritual, as we are currently seeing in the Ugandan settings. So you really have to approach these patients wholly. When you're doing the examinations, at least make sure you have done due diligence. And we know that we work in resource limited settings, but let's do our best to make sure that we handle these cases accordingly. With those few remarks, thank you everyone, and to our organizing committee and our dear experts who have been on the line.
Thank you. Mr. Ntambi, over to you.
Thank you very much. My message to fellow pre-hospital providers, I think it's high time we accepted that planning is part of a big do. If we plan adequately, I mean, we're in the best position to give the best to the little ones. Without planning, using guesswork, we might be contributing towards causing more harm than probably where they expect us to give or support the system. So I call upon colleagues that it's high time we appreciated that the country where we stand today, we are in better position to one, prepare and plan adequately, so that for any case that is probably before us, we are in the best management expected.
Okay. Thank you, experts. Once again, my name is Halima Adam. I've been your moderator for today. And right from the case presentation to the discussions by our experts, usually history taking is very important. Examination, not leaving anything out is very important, so that we come out with proper management for such children. This moment, I would like to thank all our participants, people on call. Thank you for listening in and always being consistent for attending these open sessions. To our experts, you've actually delivered. That was a good, excellent presentation from you. And I hope all the people on call have taken note from what has been discussed and will be put under consideration while managing these children. The technical team, thank you very much. SEED Global Health, Minister of Health, EMS Department, thank you so much for always making sure this open session takes place. And at this moment, I would like to invite the audience to turn on the videos for screenshots. Kindly turn on your videos for screenshots. Thank you. I see Namoga Catherine, Kebirungi Esther, Mary Nabatanzi, and also appreciating all our colleagues that has been listening in from Namibia and other countries. Thank you. And at this moment, until next time, bye. Screenshot has been taken. Bye, everyone.
Bye, and thank you so much.
Thank you, Dr. Sabrina. Bye, Dr. Gerard.
Great moderation.